is quite interesting today, right?
Very interesting, sir.
Yes.
Yeah. I think it's 7:35, so we can start now. What do you feel, Vijay?
Yes, sir. So, shall I start the intro, sir?
I think so.
So, good evening, everyone, and welcome for our MDSI journal first. Today, we have a couple of very interesting article, and they are going to discuss about the original article and the case studies and the journal blast we are going to discuss. And today, we have a couple of interesting speakers, Dr. Rinda Rao from Hyderabad, and Dr. Neeraj and Dr. Manoj Reddy from Chandigarh, and the well-known chairpersons, Dr. Sahil Mehta from PJ Chandigarh. And I'll just introduce Dr. Sahil. We all know about Dr. Sahil. He's well known about our MDSA group. Dr. Sahil is associate professor in the Department of Neurology, PGMR, Chandigarh. He has done his DM Neurology from DMCH Ludhiana, and he has a special interest in movement disorders. He is running the Botox clinic and movement disorder clinic in PJ Chandigarh. He has published almost 75 national and international publications, and he is a member of International Parkinson's Disease and Movement Disorder Society and Movement Disorder Society of India, American Academy of Neurology, as well as Indian Academy of Neurology. And we also have another chairperson, Dr. Sandhya Manoranj. She is the associate professor and head of Department of Neurology, Deccan College of Medical Sciences. And it's over to Dr. Sahil and Dr. Manoranj. Thank you.
Thank you, Vijay, for the kind introduction. I'll request first Dr. Sandhya, because her team is presenting the original article, to introduce the first speaker.
Okay, sir. Thank you, sir. Good evening to all. First of all, I thank the organizers of the Journal Quest and the MDSI for giving me an opportunity to chair this session. Today's original article with critical appraiser is brought to you by Dr. Rinda V. Rao. She's a second-year DM Neurology resident from Deccan College of Medical Science. The title is Persons with Parkinson's Disease Show Impaired Interlimb Coordination During Backward Walking. Over to you, Dr. Rinda.
Good evening, everyone. I'll start sharing my screen now. Can you see my slides, ma'am?
Yes, Rinda, you can see,
Okay.
but it is going to one side.
Um, one second, ma'am. How about now, ma'am?
Yeah, I think it looks fine, Vijay.
Yeah, fine.
It looks fine, sir.
Just a second, but the sides are not changing. I'll just stop it. share again. Can you see the slides now, ma'am?
Yeah, can see.
So good evening, everyone. I'm Dr. Rinda, second year neurology PG from Deccan College of Medical Sciences, Hyderabad. Today, I'm going to be discussing about an original article which has been published in Jan 2022, the Elsevier Journal by Grace K. Kelhar et al. So the topic of today, as ma'am mentioned, would be persons with Parkinson's disease showing impaired interlimb coordination during backward walking. So coming to the introduction. So as you all know, coordination between the arms and leg swing is a fundamental feature of the human gait. So as you can see in the diagram, when the person is walking, the right upper limb and the right lower limb, which are on the ipsilateral side, are all out of phase with each other, whereas the right upper limb and the left lower limb, which are the contralateral sides, are in phase with each other. This out of phase and in phase is very much important for interlimb coordination, and this basically contributes to the maintenance of the stable gait, and the disruptions of which increases the risk of falls. So what happens in patients with Parkinson's disease? They exhibit more variable interlimb coordination when compared to the peers and show increased variability in the timing of the arm swing. Here you can see an elderly male patient with right hemi-Parkinson's. As you can see, normally the ipsilateral side should be in case of out of phase with each other, which has been reduced in this patient. It has been shown in the study that the backward walking is more impaired in patients with Parkinson's disease. How these patients coordinate their limbs is critical in determining their mobility as well as the risk of falls. So what are the aims and the objectives of this study? To explore how this interlimb coordination is affected, especially during backward walking, when compared to forward walking in patients with Parkinson's disease, as well as the age-matched controls. The most important objective and based on the study was the implementation of backward walking as a potential rehabilitation tool, especially for patients with Parkinson's disease. So coming to the materials and methods, it's a case control study, and the study side, the patients with Parkinson's disease were basically recruited from the program for movement disorders at the Fixel Institute, University of Florida, whereas the controls were recruited from the North Florida region. The sample size included like cases of 18 patients with Parkinson's disease, and the control of 18 age and gender matched older adult controls were taken into consideration. So the inclusion, coming to the inclusion and the exclusion criteria. So the patients with Parkinson's disease, the inclusion criteria have, those patients were included, especially when the IPD diagnosis was made by a movement disorder neurologist, the modified Horn and Yahr stage of 2.5 better in the on medication state, and the patient was on a stable regimen of anti-Parkinsonism and psychotropic medications, at least for prior 30 days before the enrollment into the study. So coming to the exclusion criteria, any evidence of secondary or atypical Parkinsonism, as well as any major psychiatric or cognitive decline with MMSE score of less than 24, as well as significant motor fluctuations like an unpredictable on and off phenomenon, as well as any patients taking cognitive altering drugs have been excluded from the cases. So coming to the exclusion criteria for older adult participants, that is nothing but the controls. Any patient diagnosed with neurological condition, cardiac or pulmonary disease, insulin-dependent diabetes, or any condition which is affecting the ambulation, and significant cognitive impairment with an MMSE score of less than 24, or a self-selected gait speed of more than 1.15 meters per second have been excluded from the study. This is important. They've included only a gait speed of less than 1.15 because any interlimb coordination difference which occurred in them made sure that it was not due to any physical performance, but because of some form of underlying pathology. Inability to walk comfortably without assistance, those people have also been excluded. So basically, how did they measure this interlimb coordination as well as the various parameters was by using a Vicon Nexus plug-in gait full body model. As you can see, this is the model which is present over here, and reflective markers were placed on various bony landmarks as indicated in the diagram on bilateral sides, including the spine as well as the various joints. And a 10 camera motion capture system was recorded marker positions at 120 Hertz. So this is a 3D motion capture which was taken, especially when the patient was standing, as well as when the patient was walking. So coming to what was actually analyzed. So this is the 8-meter walkway. Forward as well as backward walking was analyzed. Then participant walked at least 5 times across this 8-meter walkway at a comfortable preferred speed for both forward walking as well as that of this backward walking. 2 important angles which have been measured with the help of a Vicon nexus. These are the relative angles, that is the shoulder as well as the hip angle. The shoulder angle is basically between the upper arm and the trunk segments, whereas the hip angle is between thigh and the pelvis. So coming to the various spatiotemporal gait parameters which were analyzed, first thing coming to the gait speed, it is nothing but the linear velocity of the heel marker during forward walking and toe marker during the backward walking. So whenever comparing forward marking, you have to take the heel marking into consideration and toe marker during the backward walking. So 2 important spatiotemporal parameters, that is the step length and the step width. So basically both of these are the horizontal distances which are measured. Step length you measure in a sagittal plane, whereas step width you measure in a frontal plane. So as we discussed earlier, that is between the heel markers for forward as well as toe markers for the backward. So what do you mean by cadence? Cadence is nothing but the number of steps taken per minute. And the double support percentage is a percentage of the gait cycle which is spent in the double support. So as you can see over here, step width is a measurement which is done in case of the horizontal distance in the frontal plane, and the step length is a horizontal distance in the sagittal plane. So normally in case of this gait cycle, you have something called as a stance phase as well as a swing phase. So what do you mean by double support? It's a point where both the feet are touching the ground. As you can see, it almost contributes normally about 20% of the gait cycle. So 2 important definitions which we have to know before we proceed further in the article, and which forms the basis of this article. So everything, the gait stability and everything which we're discussing is about the interlimb coordination. So what do you mean by that? There are 2 types. One is the ipsilateral interlimb coordination. The other one is the contralateral interlimb coordination. The name itself indicates the contralateral interlimb coordination is a coordination between the contralateral joints. So in patients with Parkinson's disease, since one side is this asymmetrical side is getting affected, one side is more affected than the other. So you have 2 possible combinations. One is the more affected hip by the less affected shoulder, and the less affected hip by the more affected shoulder. Whereas for the ipsilateral interlimb coordination, it was defined as a coordination of the ipsilateral joints that is on the same side of the body. So in this also you have 2 possible combinations. One is on the more affected side, that is the more affected hip by the more affected shoulder, and the less affected side, that is the less affected hip by the less affected shoulder. So how did you actually quantify this interlimb coordination? So this interlimb coordination, whenever the person is walking, we're always talking about it. So how do you quantify it so that you can measure it? It is basically done using something called as PERP, that is referred to as a point estimate of relative phase. So now we're going to discuss about PERP. So as you can see, as we discussed earlier, when the person is walking, so if we compare the right and the left, that is ipsilateral and contralateral, suppose we take example of the right side. So the right upper limb and the right lower limb. So as you can see on the ipsilateral side, they're always in out of phase. So what should be the angle? So angle between the right upper limb and the right lower limb will approximately be closer to 180 degrees while the patient is walking. So what happens to the contralateral limbs? So the right upper limb and the left lower limb, as you can see, they both are in phase. So the angle between them will be closer to 0 degrees. This is very important to understand. So the ipsilateral limbs are always out of phase, so the angle is closer to 180 degrees, whereas the contralateral limbs are in phase, so the angle is closer to 0 degrees. So this PERP has been measured. Then the second measurement which was done was the range of motion. It was done to ensure that whatever PERP values which are getting, it's not because of any functional flexibility differences. So how are these PERP and range of motion? Both are angular measurements. So how do you do it? They were calculated with the help of a custom MATLAB software. So coming to the assessment of the severity of the affected limbs. So the more affected side and less affected side were basically calculated with the help of the UPDRS3 and subtracting the scores on each side. As you can see, the questions number 20, 21, 23, 24, 25, and 26 have basically been included. The 22 particularly has been omitted, which is basically rigidity, because rigidity itself can result in falls. That's the reason they've excluded this from this particular study. So coming to the non-dominant limb, so what comparison was done in these basically patients between patients with Parkinson's disease and controls is the more affected side of Parkinson's disease was actually compared with the non-dominant limb of the control. So how do you assess this non-dominant limb of controls? For a simple example, like how do you, which leg do you use to kick a ball and so on. So such questions were basically asked. So coming to the, what are the measurements so far, which we have analyzed. So what is the summary of them? So the various gait parameters which were analyzed are the gait speed, the step length, the step width, the cadence, and the double support percentage. Whereas the interlimb coordination was measured in terms of perp, which is an angular measurement, and the range of motion at the shoulder and hip angles, that is also an angular measurement. Later on in the future slides, we'll know about the correlation between these two, which was also done. So coming to the statistic analysis, the various spatiotemporal variables which we have discussed for the more affected sites in patients with Parkinson's and the non-dominant sites in control group were analyzed using the repeated measures MANOVA. Whereas for each limb combination, like we discussed for the ipsilateral and contralateral sites for PERP as well as ROM for each separate angle were evaluated with the help of repeated measures MANOVA. So coming to the significance was set at a p-value of less than 0.05, but Bonferroni corrections were basically done when appropriate. So why did we do these corrections? Especially Bonferroni corrections are done when we have a small sample size with multiple variables, because even one false positive value can result in changing of the data. This is calculated with the help of the original p-value by the number of tests. As we know, we measured 5 spatiotemporal variables. So divided by that, you're going to get 0.05 divided by 5. So that is 0.01. Whereas for ILC, we measured 4 variables on ipsilateral and contralateral sides. So the p-value was less than or equal to 0.0125. So coming to something called as a partial eta2 square was also used to evaluate the effect size. So what do you mean by the effect size? Is basically the strength of the relationship between two separate variables is measured with the help of this partial eta2 square. And based on that, it has been divided into small, medium, and large. So coming to the results. So coming to the demographic information and the values that were presented as mean plus standard deviation, as we discussed, men and women were basically men 15 in each group and women were 3 in each group. Majority of them were actually men, which constituted 80% of the study population. And the age and height match, and the gait speed, as we discussed earlier, it was more than 1.15, and the controls were basically excluded. And the Hohen and Yard study of 2 ± 5, and the UPDRS of 35 ± 10, and the disease duration has been 4 ± 4 years. So coming to the PERP and the ROM value replaced by MAD. So what do you understand by MAD is nothing but a mean, median, absolute deviation, but not mean. So there are certain values for PERP and ROM when we are measuring, which are actually falling beyond the two standard deviations. So all those values have basically been replaced so that the values come under the median absolute deviation. So various spatiotemporal analysis gait cycle parameters which were done in patients with Parkinson's disease as well as control, and it was done both during backward walking as well as forward walking. All of these will be analyzed in the following graphs. So as you can see over here, this is the gait speed, step length, step width, and the cadence. So the blue line indicates patients with Parkinson's disease, the orange line indicates the controls, and VW indicates the backward walking, whereas the FW indicates the forward walking. So when you compare the gait speed, step length, step width, and cadence, especially patients with Parkinson's disease and the controls, there was no statistical significance which was basically found, including the double support system. In spite of doing the Bonferroni's corrections, there was no statistical significance. But when we are comparing the conditions, what do you mean by comparing the conditions is we're just comparing mean variables between two different groups. That is, the null hypothesis is considered as 0, and you're just comparing the mean between two different groups. When you compare that in such conditions, it was found that the gait speed was much slower, the step length was shorter, the step width was wider, and the cadence not much difference, especially in backward walking compared to that of this forward walking. As you can also see, the double support system was also, patient required more time during the double support, especially in backward walking during that rather than the forward walking. So this was done, though it was not statistically significant, but only while comparing the condition, that is the main variables, have found the significance. So coming to the range of motion, so 4 different angles, the range of motion was calculated as we discussed, the more affected hip, the less affected hip, the more affected shoulder, and the less affected shoulder. Individually between the patients with Parkinson's disease as well as controls, there was not much statistical significance which was observed. But as you can see, difference between backward as well as forward walking during this range of movements has basically been observed. So during backward walking, definitely the range of movements was much lesser in case of all of these 4 angles compared to that of this forward walking. So, and this was significant, especially in case of this most affected shoulders compared to the other angles. So what did you interpret in the ROM results? As we discussed, there was no differences in hip or shoulder range of movements between patients with Parkinson's disease and control for any joint. But when we compared the backward walking to forward walking, definitely it was significantly smaller in backward walking compared to forward walking, the most affected being the most affected shoulder. So coming to the interlimb coordination analysis, this is the most important slide which we have to understand. So as you can see over here, the more affected shoulder by the more affected hip, that is nothing but the ipsilateral side. And this is basically the contralateral side. So this is basically significant. So we'll be discussing about these two. As you can see, as we discussed earlier, what is PERP? So whenever the patient is in case of this, when we're considering the ipsilateral side, the PERP, what we discussed, always the ipsilateral side should be out of phase with each other. So the PERP value is usually closer to 180 degrees is much better. So the higher angle is much better for ipsilateral sides. As you can see, but patients with Parkinson's disease, especially during backward walking, this PERP has been significantly reduced, indicating that definitely it is affected during backward walking. So coming to the contralateral sides, as we discussed earlier, PERP for contralateral side, they should always be in phase. So the angle closer to 0 degrees is much better. But as you can see in case of patients with Parkinson's disease, especially during backward walking, this PERP was significantly higher, indicating that in the ipsilateral sides, the PERP was much lower, whereas in case of contralateral sides, the PERP was much higher, especially in patients with Parkinson's disease and during backward walking. So as we discussed, the PERP was reduced during backward walking compared to forward walking for the ipsilateral limb combination, whereas it was increased during backward walking compared to forward walking for contralateral limb combinations. So they've also analyzed the correlation between the ROM as well as the PERP for these various patients. So on the ipsilateral side, like we discussed, the ipsilateral side, the angle of the PERP should be closer to that of this 180 degrees is much better. So as the PERP is increasing, indicates that the range of movement has also been increased in case of these individuals. Whereas when we compare the contralateral side, as we discussed, the contralateral limb should be mostly in phase. So closer to 0 is basically better, but as the PERP value was basically increasing, that is the angle was increasing, the range of movements was considerably decreasing. But this showed a very weak correlation when we were comparing the range of movement as well as PRP. It was not statistically significant. So coming to the discussion, so what are the findings which we actually got from this study is that the spatiotemporal gait parameters and forward interlimb coordination were not significantly different between various groups, but the interlimb coordination, especially during backward walking, was significantly impaired, especially in patients with Parkinson's disease. So this disruption in coordination which is occurring contributes to the mobility and activity of daily living issues during backward walking, which is seen in patients with Parkinson's disease. So the lack of statistical, as we discussed earlier, there was not much statistical difference between the range of movements, suggests that any difference in case of PERP, which is occurring between various groups, is not because of any differences in joint flexibility, but it's because of some form of underlying pathology. And this impairment is mainly because of an underlying mechanism of Parkinson's disease and not related to the mobility impairments, which is seen with normal aging. So coming to the arm swing. So from the beginning of the discussion, we are discussing about the interlimb and the arm swing. So this arm swing is basically essential for successful gait performance because anytime there's a reduced arm swing, it increases the metabolic cost of the walking and it further decreases the gait stability. The functional range of motion of the more affected shoulder may be impacting the ability of Parkinson's patients with Parkinson's disease to swing their arm while walking backward. But according to this study, as we have shown before, there was only very weak correlation between PERP and the more affected ROM, suggesting that there was some other underlying defect, especially some poor neural control of smooth coordinated movements of the limbs because of dysfunction of the basal ganglion and not because of the flexibility issues at the range of motion. So coming to the critical appraisal of the article, was the research question or objective in this paper clearly stated? Yes. Was the study population clearly specified and defined? Yes. Did the authors include a sample size justification since only 18 people were included in both cases and control? It's no. Were controls selected or recruited from the same region? Yes. Were the definitions and inclusion and exclusion criteria were definitely mentioned? So it is yes. Were the cases clearly defined and differentiated from the controls? Yes. If less than 100% of the eligible cases, so were they selected random or consecutive, as has not been mentioned in the article. Was there use of concurrent controls? Is basically after study started, have they included any controls? It has not been mentioned. Were there any key potential confounding variables measured? Yeah, definitely this statistical analysis was done. How precise was pretty much precise according to the estimate of the measurement. Can the results be applied to the local population? Yes, maybe because of the sample size is less, but still it can form a basis for the future large scale studies. Do these results of the study fit with other available evidences? So there has been evidences in case of other studies where they have studied about this backward walking in Parkinson's disease, as well as interlimb coordination, especially during forward walking. But interlimb coordination and backward walking, this is the first study to be done about that. Coming to the limitations, as we discussed, it had a small sample size, only 18 patients were present in cases and control group. The present study was limited only to patients with mild to moderate Parkinson's disease. The fall history was not included in the study. Basically, if you have included that, it would help us in understanding the relationship between backward walking and the incidence of falls as well. Then what is the take-home message basically from this article? The most important point which we learned is the interlimb coordination. So in phase and out of phase, as we discussed, for proper gait, this thing. So the ipsilateral side should always be in out of phase, whereas the contralateral side should be in phase. So the impaired interlimb coordination in patients with Parkinson's disease while walking backward contributes to the increased incidence of falls. And the clinician should check for the arm swing even during backward walking in routine practice, especially in the hospital and OPD, for early assessment of the falls and progression of the disease. And this backward walking can actually be used as a rehabilitation tool, a new mode, basically to further improve the interlimb coordination and prevent the falls in the patients. And future studies should basically include individuals at various stages of the disease progression, to basically investigate how this coordination during backward walking is impacted by more severe Parkinson's disease. Thank you.
Thank you, Rita, for the excellent presentation. I may ask the panelist. Anything, sir? Anything to be added? Any questions?
Dr. Rindha, very nice presentation. I just wanted to ask what was the basis of doing like backward walking specifically in this study? Can you just elaborate a little bit, because they have just done very complicated parameters and all.
Yeah,
Where the routine gait cycle must be there, they must be doing all this. But for routine benefit of the residents, can you just lay down the important points, why they did the backward walking and what was the implication of HNY2? As far as I think that HNY3 is considered as the patients with Parkinson's disease has gait impairment.
Yes, sir. So basically, HNY2 or more has been taken in case of this population, sir. So basically, 2 indicates bilateral disease without much postural instability. So that is the reason they've included in the study. The second question which you have asked, sir, is so basically backward walking. So patients with Parkinson's disease compared to the forward walking, it is shown that they have more falls mainly related to this backward walking, especially while performing this tasks. So normally when do you use this backward walking in routine tasks, especially while washing of the face or some of the routine activities which require sudden backward this thing. So in those conditions, these patients have shown to have more falls, sir. So that's the reason they measure this interlimb coordination during backward walking, which has not been done before.
But the results you showed that they were not significant between the Parkinson's patients and the control groups.
Yes, it was not statistically significant, but when you do this variable studies, so when you're measuring the various variables and all that, it was shown that definitely during backward walking, it was comparatively impaired compared to forward walking. But as I said, the sample size is very small to establish it to the general population.
Sir?
Yes, Doctor.
Actually, prior studies have shown that there is backward walking is impaired in patients with Parkinson's disease, but they did not. This is a new study where they have compared the interlimb coordination in backward walking in patients with Parkinson's disease. Actually, they found that though in compared to forward walking, backward walking plays main role in the postural instability and gait. And then this is a new rehabilitation mode also in patients with Parkinson's disease and early detection for progression of the disease also. So actually this forms the basis for further studies.
Okay. Any comments from our senior panelists?
Hi, Dr. Sahil. Can I comment?
Yes, sir.
1 minute. Rishikesh here. First
Yes,
of all,
sir.
this presentation was excellent. And this is almost an ideal presentation, which residents should learn that very crisp. And wherever the terms were complicated, she explained that. She finished in time. And after that, she gave a very clear critical appraisal. So this is a wonderful presentation, Doctor. So that's one. Second thing is that Sahil, whenever they do gait study, especially gait parameters, they usually choose grade HNY2 because by the time HNY3 comes, a lot of postural imbalance comes. Then it has completely different connotations. So stage 3 generally they use. Third, I would say that in stage 2 also, each patient is different. So it's very difficult to generalize the finding at this point in time because think of a patient having tremor dominant Parkinson disease stage 2. Think of a patient with PIGD stage 2. Think of a patient having bradykinesia more in the upper limb versus more in the lower limb stage 2. So this itself is a very heterogeneous population. So in such case, if we have to conclude something, we should have a huge population so that each subgroup is well attended. So this is what I feel. I think the more numbers would have been better, but it's a wonderful presentation and it's an interesting article.
Thank you, sir.
Dr. Ravi has asked a question. Is there any data present among tremor dominant versus other PD subtypes?
Sorry, sir.
Did they classify your patients amongst tremor predominant versus
No, sir.
big D types?
No, sir. In this classification, the UPDR is 3. The older edition was basically used to just know the more affected side from the less affected side, sir. They haven't classified based on individual characteristics.
Okay.
That's an excellent question, Dr. Sahil, because both behave so differently as Gait is compared. So whenever nowadays they design some study, they try to do tremor dominant as and PIGD separately, or they have subgroups. So it's an excellent question.
Maybe future studies can answer this question.
Yes, sir. And also more number of patients can be recruited and done.
And one thought is coming to my mind, like in freezing of gait patients, we usually advise, sometimes on backward walking, the freezing of gait improves. But here they have documented that these spatiotemporal gait parameters are more impaired during backward walking.
But they were not statistically significant, sir.
But their main hypothesis is that in PD, the backward walking is much more impaired than forward walking.
Yes, sir.
So any comments, sir, on that, Dr. Rishikesh?
Not really. PD generally backward walking is more impaired. I don't have any data or don't have any point to tell about it. I don't know about it.
So we have seen a couple of patients who underwent post DBS. We try to analyze when we do the gait analysis or even in gait mat, the backward walking is more impaired and they tend to fall more when they're doing backward walking. So, but we are not published anything, just an observation.
Okay, sir.
Sir, if there are no more questions, shall we proceed?
I think so.
Dr. Inda, you can stop sharing your slides. So I invite the second speaker for today's session. He is Dr. Neeraj. He's a DM student from our institute PGI Chandigarh and is now currently working as an assistant professor. He's a very sincere and hardworking colleague, and he has chosen the field of movement disorders, and we are actively doing working as a team here. So I request Dr. Neeraj to share his slides and present.
Thank you, sir, for wonderful introduction. Now I am sharing my screen. Good evening, everyone. First of all, I want to thank the organizers and Dr. Sahil for giving me opportunity to present on this forum. So today I am presenting the journal blast for the session. So let's start with our first journal article. That is the articles are to be presented from Parkinsonism and related journals. So the first article is long-term effect of bilateral subthalamic nucleus DBS on non-motor symptoms in Parkinson's disease. It's a 4-year observational prospective study. So coming to the PICO of the study, just I have tried a pictorial PICO. So this is an observational study and in which 40 consecutive patients treated with bilateral subthalamic nucleus DBS were included. And out of which 12 were excluded and 28 were analyzed, and they were followed up. Non-motor symptom scale score was done at baseline and other scores, but the primary outcome was non-motor symptom scale score. So it was analyzed at baseline, and then patients were followed up at 6, 12, 24, 36, and 48 months. So in the primary outcome, NMS score, that is non-motor symptom scale score, that improved up to 24 months in this study and then further deteriorated as depicted in the graph also. So up to 24 months, its score improved, but later on it deteriorated. So the outcome was that non-motor symptoms score improved till 24 months and then deteriorated at 48 months or 4 years. So the rationale of the study was that previous studies which are available with us for non-motor symptoms are up to 3 years post-surgery. So they further extended the study period for a 4-year follow-up. So for the inclusion criteria was PD patients which underwent subthalamic nucleus DBS study, and the patients who were assessed at all 6 points in the study were included. The patients who were having back depression inventory score more than 16 at baseline were excluded, and those having perioperative complications were excluded. So the primary outcome was again non-motor symptom scale, and other scores and scales which were used were MoCA, Beck's Depression Index, Hamilton Anxiety Scale, Apathy Scale, Parkinson Disease Sleep Scale, H&Y, MDS, UPDRS, and levodopa equivalent dose was collected and follow-up was done as already shown. So this was the baseline data. So 28 patients were analyzed, and what they found, this is the non-motor scale score. So at baseline, it improved at 24 months, but at 48 months again, it went down. This I have already shown. So the MoCA, it remained almost the same for the whole of the study period. The anxiety scale, it improved for up to 6 to 12 months and then again deteriorated. The apathy scale, it continued to worsen for the study period. The sleep quality in Parkinsonism PDSS2, it improved during the study period. And what is interesting to know that the MDS UPDRS part 3 and levodopa equivalent dose, MDS UPDRS, it improved till the end of the study. That means the motor improvement continued to persist, but despite that, the non-motor symptom scores, they worsened. So what we found through this article, that non-motor symptoms, they improve up to 24 months after ST and DBS, anxiety up to 12 months it improves, and depression improves till 6 months, and sleep quality improves overall. Cognition remains stable, but apathy worsened. So the one possible reason for this finding is that DBS is not a disease-modifying treatment, and due to natural progression of the disease, non-motor symptoms also worsen. So there are few limitations of the study, like small sample size, single arm study, and a single center study, and being an observational study, the inherent limitations of the study. So why this study is important? Because we can counsel the patients regarding non-motor symptoms perioperatively, what to accept in a short term and then in a long term basis. So that's why the study is important. Now, next, coming to our second study from the same journal, that is executive function and dopamine response in Parkinson disease, freezing of gait. So again, coming to the PICO of the study, in this study, 44 individuals with Parkinson disease from movement disorder clinic was taken, and they were divided into 3 groups. The one group with the Parkinson disease without freezing, which acted as control. Then the patients who were having freezing of gait, but it was DOPA responsive. And then the third group was DOPA unresponsive freezing of gait. So they did neuropsychological assessment in all the patients, basically mainly set switching in all the patients, seeing the time and errors, and freezing of gait severity was measured using new freezing of gait questionnaire, and timed up and go tasks were obtained along with dual and without dual cognitive tasks. So in the after comparing 3 groups, they found that there is increased set switching errors in the DOPA unresponsive freezing of gait relative to PD control and those having DOPA responsive freezing of gait. Other groups were not different in other cognitive domains. So the rationale for the study was they wanted to demonstrate dopamine response in executive function as well as freezing of gait. So they included the PD patients and they excluded the patients who had MMSE score less than 26 or DBS was implanted, and divided into 3 groups as I told, and they did a detailed neuropsychological battery along with freezing of gait score and UBTRS 1 to 4 and timed up and go tests. So what did they found? That there was significant set switching errors which were more in the DOPA unresponsive freezing of gait patients. So this is association between adjusted set switching error and freezing of gait severity. So it was found that freezing of gait severity, as it increases, the executive function also worsens in the patient. So this is the different measures or different scores which they have calculated, but it was not significant statistically. So only thing which they got was the set switching errors, which were more in the DOPA unresponsive freezing of gait patients. So they discussed in this article that dopaminergic pathways in prefrontal cortex, they play a role in both motor and cognitive deficits. So the patients who are having freezing of gait, but they are DOPA responsive, that means that the dopaminergic pathways, they are helping the patients both in cognition as well as freezing of gait when dopamine is given. Now coming to the next article from the same journal, it's the plasma neurofilament light chain as a biomarker in Wilson's disease. Neurofilament light chain we are seeing everywhere nowadays, starting from MS, now in Wilson's disease also. So coming to the PICO, so they took 75 Wilson disease cases, from which 54 were neurological Wilsons and 21 for hepatic Wilsons, and they took healthy controls also, which were 27 in number. So they measured the neurofilament concentration, along with they did MRI of all patients, of most of the patients, not all, and they did the scoring, unified Wilson disease scoring, and they found that the plasma neurofilament can be used as a biomarker for neurological damage in patients with Wilson's disease. So this I told what they did. So this was the finding. So those having neuro-Wilson's disease, the plasma neurofilament concentration was higher as compared to those having only hepatic Wilson's disease, and those compared to controls. And at level of 5.45, they found the specificity of 85% and sensitivity of around 90% to differentiate neuro-Wilsons from hepatic Wilsons according to neurofilament levels. And there was linear correlation between plasma neurofilament concentration and unified Wilson disease rating scores. Also, they found the linear correlation between plasma neurofilament levels and urinary copper excretion in 24 hours. But the correlation coefficient was not very much high. And again, they divided the patients into stable and unstable patients. Unstable 1 patients were those patients in which unified Wilson disease score changed more than 2 points over 1 year. Unstable 2 patients were those who were newly diagnosed neurological Wilsons. Unstable 3 were hepatic patients who developed new neurological symptoms within 6 months. So when they compared neurofilament concentration in these patients, they found that neurofilament concentration was, light chain concentration was higher in patients who were unstable as compared to the stable patients. So they compared tried to correlate the neurofilament levels with the volume of different structures in the brain, and they found significantly that if neurofilament levels are less, then the volume of putamen, they found a correlation between neurofilament levels and loss of volume in bilateral putamen, bilateral nucleus accumbens, which was statistically significant. So they concluded that plasma neurofilament can be used as a promising biomarker in Wilson's disease, especially in neurological Wilson's disease. But there was low correlation coefficient between neurofilament concentration and unified Wilson's disease scoring, indicating that the neurofilament light chain level has limited use to reflect the severity of neurological symptoms directly. So it cannot be used as a diagnostic test yet. So it needs more studies and validation. Coming to next article. It's the postural and gait symptoms in de novo Parkinson's disease patients correlate with cholinergic white matter pathology. It is again a novel disease, although an observational study. So what they did, they took 98 treatment-naive patients and divided them into tremor-dominant Parkinson's disease and PICD variant of Parkinson's disease. 44 were tremor-dominant and 54 were gait-dominant Parkinson's disease, and 10 were healthy controls. They did diffusion-weighted imaging and diffusion tensor imaging in all of the subjects, especially focusing on the nucleus basalis of Maynard, which exerts cholinergic connections to all over the brain. And they showed that there was significant lower fractional anisotropy in the proximal medial and lateral nucleus basalis of Maynard white matter tract in both hemispheres in those patients which were having PICD variant of Parkinson's disease. So this was a first kind of study which was done. Nucleus basalis of Maynard was not studied via functional imaging till now. So they took 114 treatment-naive PD patients and classified according to motor phenotype. Cognitive function was tested, MRI, DWI, T1 flare, fractional anisotropy, and mean diffusivity was calculated. So what they found was when multiple linear regression was done in respect to the PICD variant, they found that the nucleus basalis of Maynard and as a whole and in the distal part, there was more degeneration in the nucleus basalis of Maynard in the PICD variant patients. And they also calculated the attentional function in correlation to the nucleus basalis of Maynard degeneration. So they found that the degeneration corresponds to the attentional function and PICD severity independently, but attentional function is nucleus basalis of Maynard is not causing PICD severity via its effect on attention. So they demonstrated significant interrelation between nuclear basalis Maynard white matter tract integrity, attentional function, and gait impairment, which is first of a kind study done by them. Now, last article from this journal is Nocturnal Stridor in Multiple System Atrophy, a video polysomnography and clinical features. So again, they took MSA patients. It was a retrospective observational study. So they wanted to study they took 49 MSA patients who underwent video polysomnography for indications like difficulty in sleep, apnea, or stridor. So then they classified them into two groups. Those who were found to have stridor in video polysomnography, they were 31, and those without stridor. So what they observed was that the patients with stridor showed higher apnea, hypopnea, respiratory disturbances, and oxygen desaturations as compared to those who were not having stridor. So just coming to the results. So this is the patients with stridor. They showed that apnea hypopnea index was higher in the patients with MSA with stridor. Respiratory disturbances were higher, and oxygen desaturation was more in patients with stridor. Then on binary logistic regression, they found that the stridor, nocturnal stridor in MSA patients is present when the duration of MSA is more, or when axial motor features are more, or when the daily activities of living are affected in patients. So again, pictorial representation of these findings. The patients who were having stridor, the axial motor features were more in those patients. Duration of MSA was more in those patients, and they were more dependent in their activities of daily living. So what they concluded that axial motor features, longer disease duration, and impaired activities of daily living are associated with presence of stridor, probably due to common pathophysiology, which is widespread brainstem dysfunction, which leads to stridor due to longer duration of the disease. So these were the articles from the Parkinsonism and journal, and thank you for your patient listening. Thank you.
Thank you, Dr. Neeraj, for the excellent presentation and short synopsis of newer findings in so many diseases. I just want to ask you one question about the neurofilament light chain. A thought came to my mind. Are there any studies, or did they study anything like in routine clinical practice? Sometimes we have problem whether the patient is actually worsening or the worsening is after the introduction of penicillamine.
Yes.
Does this new biomarker neurofilament have some role, or there is still data?
They haven't studied in this study, sir, but I think there should be a role, and it can be a good study, because neurofilament light chain is released only when the neurons are degenerated. So possibly the study may come, or we sometimes if someone hit this idea, he may do study, but they haven't studied any role of penicillamine in this study or comparison with the treatment in this study.
Okay. Any comments? Anyone?
Yeah, Sahil, I have one comment.
Yes,
the
sir.
Neurofilament is, Dr. Neeraj very well presented, and he told that I think they are exploring in all the neurological diseases. But whatever we know, I think it is quite useful in differentiating atypical Parkinsonism from PD. That is one important application which, after reviewing, we see PSP versus the PD. So there, I think, and in otherwise, it's really an interesting area of, and ultimately it points out towards the degeneration. So
it is being studied in a lot of diseases, even
Yeah.
multiple sclerosis. There are lots of studies in Alzheimer's. Recently, only we had a journal club on NFL in multiple sclerosis, probably 1 or 2 weeks back. Yeah.
So we need to have healthy control, but variations are there in the values and the way that it is assessed. That is another problem. The lab, how it assesses, the process, how it is assessed. Yeah, thank you. Very well presented.
Thank you.
So another important study which Dr. Neeraj highlighted was the executive function and freezing of gait. Probably there are quite a number of studies. Even when I was going through the literature, there's a study from NIMHANS only, where they have compared the executive function in patients with freezing and without freezing. And as mentioned, freezing involves the frontal subcortical circuitry. And there are lots of MRI and even functional imaging studies which suggest the role of frontal, and even there is on structural imaging or voxel based morphometry, there is involvement of the posterior parietal gyrus and even cerebellum. Probably all the networks are getting affected.
Absolutely. We actually, some of in our center, I think with RBD, it was found with RBD association of more of freezing of gait and more of these findings. And I think Abhishek Lanka did this study, and another one was also done by a PhD student. So RBD also, goes hand in hand with this.
Okay.
So, yeah.
So if there are no more questions, I invite now Dr. Manod, who is a senior resident at PGI Chandigarh, and he'll be presenting a short case which was published recently in the Annals of Movement Disorder Journal. Over to you, Manod.
Are my slides visible, sir?
Yes.
Good evening, everyone. I'm going to present session 3 of today's general quest. Before presenting, I want to thank you, MDSA Society, as well as Dr. Sahil sir, for providing me this wonderful opportunity. This short case, this case witness title was Huntington's disease presenting as adult onset Tourette, published in Annals of Movement Disorder under volume 4 and issue 3. This was published by Sri Chitra Institute of Medical Sciences. He is a 30-year-old male born to a non-consanguineous marriage, presented with a 3 years history of involuntary vocalizations and involuntary movements in the form of blinking, pattern rotation of the neck, and perioral as well as lip movements. These involuntary movements are associated with premonitory urge as well as and they are partially suppressible also. Later on into the illness, patient also developed cognitive impairment as well as other behavioral disturbances in the form of anxiety, depression, and suicidal ideation. There is a family history of maternal death. However, the reasons for maternal death was not known. On examination, patient is on cognitive examination, his MoCA score was 11/30 and Beck's depression inventory score of 24/63, which classifies as a moderate depression. Coming to his video of his movement disorders. I think my video is visible and audible.
Yes.
So here. So here we can see there are repetitive recurrent head rotatory movements in the form of right side neck rotation. Along with patient also had some shrugging type of movement on the right side. And we can see as a close-up, he is having pouting type of perioral as well as lip movements. As a close-up, we can see these movements. And however, there is no other associated movements in the hands as well as limbs, lower limbs. Along with this movement disorder, patient also had ocular movement abnormalities, which we can see now. As we can see, there is a lag of saccadic movement as well as slow saccades, as well as there is slow to initiate function of saccades also. So patient had tics in the form of neck rotation as well as perioral movements in the form of pouting, as well as some right hand shrugging of the right shoulder, along with the slowness of saccades and slow to initiation as well as movement also. So in the presence of oculomotor abnormalities, along with as in the presence of cognitive impairment as well as and oculomotor abnormalities, we can't classify the patient as a tic disorder. So the patient has actively searched for other secondary causes of Touretteism or tic disorder, and workup was sent, which includes there is ceruloplasmin levels are normal for Wilson, and there is no K-free, and peripheral blood also showed no acanthocytosis, and his MRI showed there is atrophy of the caudate nucleus. Some atrophy of the caudate nucleus with the dilatation of the ventricle we can appreciate here. So he was after counseling, he was sent for a genetic triplet nucleotide expansion panel, CAG triplet nucleotide expansion, which came out to be positive and allele 2 with 44 repeats. So diagnosis of Huntington's chorea was made. So coming to the discussion part, as we know, tics are sudden, rapid, recurrent, non-rhythmic motor movements are vocalization, which are associated preceded by urge and which are partially suppressible and under the background of a normal voluntary motor activity. We can say the patient is having tic disorder if the tic disorder usually associated with a neuropsychiatric disorder, usually in the childhood onset with vocalization or involuntary movements. So we can so coming to the simple pathophysiology of tic disorder. main pathophysiology is mainly tick generation is mainly mediated by cortico-striato-thalamo-cortical circuit. This CBG circuit has multiple circuits, include motor circuit as well as limbic circuit as well as associate circuit. This motor circuit, which in turn has both direct pathway as well as indirect pathway. Indirect pathway has which has extra GPI as well as subthalamic nucleus in the indirect pathway. Which is there is inhibition of indirect pathway and facilitation of direct pathway, leading to the tick generation in CBG circuit. And other limbic and mesolimbic circuit, which is responsible for the generation of premonitory arch and comorbid symptoms in the patient with tick disorder. So we can classify tick disorder as primary tick disorder if the patient is having motor ticks, multiple motor ticks or more than one, along with one vocal tick of more than 1 year duration. We can classify them as a Tourette syndrome. And other cases, secondary Tourette syndrome or secondary Touretteism or secondary tick disorder is called as Touretteism, which should be actively considered in the presence of other atypical features. So we can most important causes of secondary tick disorder or Touretteism include neuroacanthocytosis. Inherited causes include Huntington's, neuroacanthocytosis, Wilson, tuberous sclerosis. Literature showed these inherited condition can have secondary tick disorders. And post-infectious immune-mediated include pediatric autoimmune neuropsychiatric disorder with post-streptococcal infection. Drugs and toxin can cause tick disorder. So in short literature review, I have found some in patient with choreoacanthocytosis, only 1/3 of the patient are having vocal tics, and however, and motor tics in the form of facial tics are only case reports are available in choreoacanthocytosis. And they can also have behavioral disturbances similar to the Touretteism, Tourette syndrome in the form of they can account for 2/3 of the patients. And MRI findings quite similar to the Huntington's disease with the atrophy of the caudate nucleus. Pantothenate carries associated neurodegeneration at a particular atypical pecan. Tics literature showed only few case reports. Only 8 case reports are there, which showed a secondary tourism as caused by pecan. And they can also have similar neuropsychiatric disturbances like Tourette syndrome in the form of depression and OCD and the emotional liability also. But MRI feature as specific if we found a eye of tiger sign, it is specific for atypical pecan or pecan. And Wilson disease, which is a common treatable movement disorder, we should also consider in any patient. And there are tics as our secondary tick disorders are only case reports are present, and most of them from Western world, and there is no case report present from India. And they can also have some neuropsychiatric disturbances like depression, bipolar disorder in 20-30% to 30% of the cases. So coming to Huntington disease, there are only few case reports on Huntington disease which are presenting as a tick disorder. So most of them are associated. Most of these case report tick disorder associated with the other movement disorder like chorea and other things. But isolated tick disorder is only 2 to 3 case reports are there. As we know, Jankovic et al. First case report in 1995, which published in 1995, which had patient present with tics, predominant tics along with chorea also present. And recent Lesinski et al. And Alonso et al. Also had case report also showed tics as a presenting feature along with some behavioral disturbances in a patient with Huntington's disease. So this is the case series. This is an observational study on 155 patients done by Joseph Jankovic, which out of 155 patients, only 3 patients there are chromosomal abnormalities are found in 16 patients. Among them, only 3 patients are caused by 2 patients are caused by neuroacanthocytosis, and only 1 case is caused by Huntington disease, which accounts only 0.6% of the cases. So, take-home message of this short session of general quest: if the patient is having a tic disorder or Touretteism, in the background of atypical neuropsychiatric feature or any cognitive disturbances or accumulative disturbances, secondary causes must be actively searched, like particularly Huntington's disease. Thank you.
Thank you, Manoj, for
Yes,
a
sir.
very nice and lucid presentation and a very good and unusual case.
Thank you, sir.
Any experience of Wilson's disease with ticks? Because Wilson's disease is quite common in India. I have not seen till date. Maybe some others can highlight if they have seen. Vijay, any experience?
No, I have not seen a Wilson's with ticks. Sorry. It's very interesting, actually. Probably, if Ravi sir is there.
Hello,
because-
hi, this is Vika from YouTube. We had a patient of
Dr. Deepika, you are muted.
Yeah. Try to unmute.
and she's the
I think ma'am's connection is not clear.
hello.
Yes, yes.
Hello.
Yeah, you are audible,
Hello.
ma'am.
Hello.
Yes, ma'am, we can hear you.
Hello.
No.
Hello.
You are audible, ma'am.
Yes, we had seen a patient of Wilson's disease, and she was having vocal tics. Actually, when we saw her during COVID time, ultimately we lost the patient, but she was having vocal tics and like she used to vocalize, but it was mistaken for a psychiatric problem. And throughout the time, the psychiatric was giving her lot of antipsychotics, and then ultimately she developed NMS. We've published it as an abstract in MDS. So that was one case where in the videos we saw what the father had shown, that they were vocal tics, but they were sadly, it was mistaken for a psychiatric problem, and that is why the delay was there. So otherwise, so that was one case, vocal tics.
It's very interesting. The Ravi sir is there?
Yeah.
So you have a lot, like a large series of Wilson's in demands. Do you have any experience, sir?
But actually that is part of a different unit. But overall we see a lot, but it's quite rare. Dystonic tics and clonics and vocal tics, I don't think I have seen any. Other, like, in some phase of treatment, for example, early phase or late, it may come some time, but vocal tics, I don't remember I have seen.
Thanks, sir.
Manoj, in the patient you presented, there was no chorea, only tics were the involuntary
Yes, sir.
movements.
He presented with only tics. There are no other associated movement disorder. Even chorea was also not there, as provided in the video also, and as provided in the case report also.
And what was the maximum duration they mentioned till the patient was followed up? Like,
Sir, for last 3 years only, that case published maybe at 3.5 years.
okay.
Yeah, Dr.
And
Shyam
maybe
here.
later on he may go on to develop other movement disorder also.
So Dr. Sham is there probably.
Yeah.
Yes,
He is on still on follow up. He has in fact developed chorea now.
okay.
He maybe 2 months ago he has come and he has clear cut convincing chorea now. So tics was probably an initial manifestation only.
Okay.
In fact, the late presentation and the caudate atrophy were the features which made us look for Huntington's in this patient.
Yeah. And very nice depiction of oculomotor apraxia in the video.
In this, just a tics, we won't think about Huntington's as a initial diagnosis, differential diagnosis.
Yeah.
It's very
The
interesting.
MRI only made us think of it.
Yes, sir.
MRI and with ocular findings.
Interesting. So any other questions?
There are no questions in the chat.
Yeah, shall we conclude? I think let's see anything is there. Yeah, nothing more. So there was a today we had a wonderful session with Dr. Rindara, who has presented the Interlimb coordination in affected during the backward walking, and she has initially told that the perp was affected in the ipsilateral side, and the contralateral side the perp was really higher. The ipsilateral side it was less. And Dr. Neeraj has presented a couple of journals. He told that in bilateral ST DBS the sleep was improved and depression was improved. It was very interesting. We know that the sleep was improved because of the motor symptoms was improving, and the depression, that's interesting feature, because we always think that the depression and the cognitive impairment usually worsens after sometimes with DBS. Here the study shows that the depression was improved, as well as apathy, which is another feature which was worsened in DBS. And a couple of interesting studies they presented. The executive function in freezing, especially the set switching errors was more in DOPA unresponsive freezing, as well as the neurofilaments were increased in most of the diseases. And the PAGD group showed significant fractional anisotropy in the nucleus basalis minor degeneration, as well as white matter integrity. And as we know that the nocturnal strider was more in axial motor features, as well as long-standing disease duration with multisystem atrophy. And Dr. Manoj has wonderfully depicted the patients with tics present as a presenting feature of Huntington's chorea. All are very, very interesting. We are all learned a lot of new points in this journal club. Thank you. Thanks for joining with us, everyone. And thanks for the presenters and the chairpersons for